everybody. Welcome to Compliance Deconstructed. You are hosted by Jessica Zeff, Elvan Baker, and Lorie Davis. You know you love us. So today we're going to talk about the Medicare Final Rule, and we have a really great conversation going on. Lorie's going to kick us off with just a very brief general summary of what the rule is saying, because it is kind of cool. There's a lot in there. And then we're going to have a discussion about some of the key points of the rule and how that really affects us as compliance professionals in our organizations. So, on that note, Lorie, can I hand over to you?
Absolutely. Thanks, Jessica. So, first, what is this? So, every year they update the rules, what you can, what you can't, what pays, what doesn't, coding, all of that, and what's known as the Medicare Final Rule. And it typically goes through a few stages. Right now, it's out on what's called the Federal Register. So, that's where you can review it. If you have comments, concerns, questions, you can post them there. And then it will get taken in, and this will become effective as part of fiscal year 2026. And you may be
Sorry,
saying,
Lorie.
yep,
Who's they?
they is
I
the
had to
federal
laugh.
government, the Centers for Medicare and Medicaid Services, or
They, them over
CMS.
there.
The shadowy overlords, when I talk about them. No, I'm just kidding. It's CMS. The services, they provide Medicare, and they administer in conjunction with the state's Medicare Advantage. They have oversight with the states for Medicaid, CHIP, as well as the Affordable Care Act, ACA, Obamacare, whatever you want to call it. So, as I said, this happens every year. When does this become effective? Fiscal year 2026. And you may be saying, oh, Lorie, when does fiscal year 2026 start? That's right, October 1st, 2025. So I know. And it goes through September 30th. So you may be seeing in the news right now that the Congress is once again having the great conversation about funding of the government. Essentially, in the next 13 days, if they don't get something passed, the federal government will need to shut down ahead of the start of fiscal year 2026. So, all of that aside, what is in here? There's a lot in here. And if you have nothing better to do or you like reading regulatory guidance, there's 130 pages for you. I will say that on page 3 of the Federal Register is a nice summary that is out there that I briefly want to kind of cover. And I am referring to my notes, so I may not be focused entirely at the camera.
So,
We're
just
going to
for our listeners, this is why Elvan and I adore Lorie. Did you hear her say page 3? And when we were prepping for this episode, she was like, right, guys, let's go to page 3. And we worship Lorie for this,
We're
just
like,
so you know.
scroll, where?
We love her so much.
So, in full transparency, if you're looking at the actual Federal Register, it will not say page 3. It will say page 15764 or something like that. Anyway,
Course.
so what's in here? There are a lot of great changes. We're going to touch on a few of them today. The big one is cost sharing for adult vaccines. We'll talk about why that matters. Cost sharing for insulin,
Mhm.
Medicare prescription payment plan, and what they call prescription drug events. So we want to talk about that. The data module, those concurrent reviews that we talked about, and changes to stars, what goes into star ratings. So why does star ratings matter? That could probably be its own episode, but it really determines how well your plan is rated, determines how much funding or how much money you can receive. And it also, when enrollees are reviewing plans, they look at those ratings and they may make a decision to go with a plan or not go with a plan based on your star rating. So that is a consideration here. And our friends that are enrolled in what are known as dual eligible plan, or DSNPs, meaning that you're eligible for both Medicare and Medicaid, you will also be impacted by the changes here. And there's a few other ones. I'm trying to go quick, Jessica, I promise.
You're
Risk
good. You're good.
risk as risk adjustment data submission, so that RADV that we have talked about previously, that's impacted here, as well as PACE, which is for seniors, and cost plus plans, and then supplemental benefits for chronically ill, or what's known as SSBI. So many acronyms, so many acronyms. I think we need to have an episode just dedicated to acronyms and what they mean. And then there is a whole section on hospital inpatient prospective payment system updates. We're not probably going to get to that too much today, but there is a lot going on there. So I think if you're in this space and you need to look at it, that's definitely things that you want to look at. So that's kind of the final rule in a nutshell. Hopefully I have given it as much of a comprehensive overview as I can to turn it over to Elvan to talk about one of these components.
I want to talk about one of the things that was very exciting for me. That's a big topic in our conversations in my personal life is the insulin prices. When the first glimpse of this news came out during the Biden administration, it became a huge buzz. Why? Insulin for many, many people, especially for those who are insulin dependent as type 1 diabetics, this is a life saving medicine. They do not have the option to take it or not take it. It really is not to be confused with maybe even with type 2 diabetes, where there is a little, you have a little bit more control over your own body's need of insulin, because there's a little bit more you can do as far as diet, exercise, lifestyle changes. But people with type 1 diabetes, what used to be called the juvenile diabetes, their pancreas no longer produces insulin. Therefore, they need this medicine. They do not have the option to take it or not take it. What they eat, what they do during the day may decide how much of it they need to take, but they need to take it. It's a life-saving medicine. So when the buzz started back in the day, when it was Biden administration, and it was actually pretty early on in his administration that he made the headlines with the news that the price of insulin would be capped at a certain amount. And that certain amount was $35. The good news is that now there's attention. The work started as to how we can cap the price of insulin, because this is a life saving medicine that a patient needs to take every single day, every single meal, almost every single hour at a certain rate. But it really did not go into effect up until now. And while it was good that the buzz started back in the day, people also missed the fact that when he said this was going to be in effect, it was for CMS, right? For those beneficiaries.
Mhm.
It really did not mean anything for those people who are under commercial insurances or, employer sponsored insurances.
So those who
So,
were who are on Medicare,
yes,
that's who would it affect.
yes, who are under Medicare or Medicaid, the price would be capped. But still, I was really excited because it starts with CMS. It starts with the buzzword. It starts with the headlines that now there is attention to this disease and life-saving medicine. And usually that's what we need. When administration comes in, they put the spotlight on this disease, and we see the slow but for sure movement towards it. So
Yeah.
now we are in that final phase with the final rule where the price of insulin will be capped at $35. Why is this important? Because, first of all, as the disease progresses, you don't know how much your body is going to need, but it will need it. So when the patients are able to calculate how much it's going to cost them a month, they're able to utilize the money that they save from this on other parts of their diabetes management. Because while the insulin price being capped is fantastic, how are you going to deliver that little vial into your body, right? It needs to go into your bloodstream. There are many ways of doing this. Some people use an insulin pump, some people use syringes, a little bit more old school, but that's what some people like. So saving the money on the medicine itself will allow people to be able to budget and invest the money into the other supplies that still controls their disease process. So I'm really excited about it. There's a little bit more caveats, obviously. Yet again, this is a CMS rule, but this is where it starts. Once this starts, manufacturers also know that the writing is on the wall with their high prices. So they start coming up with assistance programs. They start talking to different commercial insurances. So this is just the beginning, but I'm really excited personally because of a very dear loved one has type 1 diabetes in my family, and this means that we can control our expenses just at a better rate. Again, just because they need it, they don't have the option of using it or not using it. What do you think?
Yeah.
Sorry, Lorie, go.
Yeah. No, Elvin, I want to be clear. It's capped at $35 or 25% of what's considered the maximum fair price if it's part of the Medicare drug price
Mhm.
negotiation program, or it could be 25% of the negotiated price of the plan. So it may be less than $35, but $35 is the max. So I just want to make sure that in full
And I
transparency, folks
will,
have the info when they look at the final rule and they're like $35, but there is a set of medications, to Elvan's point, that was negotiated under the Biden administration that is capped currently at $35. So
and
I
I
just
will
wanted to
give
add that.
a one-on-one comparison before I turn it over to you, Lorie and Jessica. But back in 2020, I'll give you an example. The person showed up at the pharmacy. They had commercial insurance. This was just about the time where that buzzword came about. We get excited. We know this is just a buzz at that point. The rule has not passed. Not a ton needs to be done. We show up for 3 vials of insulin. It was over $750 out of pocket. This is with commercial insurance, guys. This is unbelievable. The same order today from, I'll give the name, from Amazon Pharmacy is delivered to a person's house for about $10 a vial. Huge difference, huge difference, huge difference in the
Huge.
quality of life. I mean, it's a one-on-one comparison. I think until we hear the numbers, it really doesn't click what it means, but it's a huge difference that the person gets to invest the rest of the money into their overall well-being because they still need to stay upright, if I say so myself.
Yeah.
No, and
Yeah.
that's a really, I mean, that's a great segue to illustrate the importance of this change in the final rule because it's going to have a huge impact on patients, on members,
Mhm.
and on the whole health ecosystem. So if you think about healthcare providers or you think about payers and health insurers, what does all of this mean? It's not
Mhm.
a small change. The impact is huge if you think about it. Right?
And
And so that's a really great story of how many people are gonna need this and what so as we
mhm,
think about compliance and the impact on organizations of these rules, why don't we take just a few minutes to talk about that impact? Because it is huge. And then we'll move on to talk about vaccines a little bit, right? And our other topic around concurrent
mhm.
evaluation. So when we talk about the impact, what are organizations going to need to do? What do they need to think about and change? So, we had a big conversation yesterday about this at our prep session. And some of the things that Elvan, Lorie, and I were talking about. Elvan, I'm sorry. Were you going to say something else?
No, no. I mean, no. This is great. Let's talk about compliance because this is a subject I can mumble on forever, and there is really no need for it. But ultimately, this change will help actually overall organizations and the health system save money because you take care of a chronic disease that will have lesser effects on your acute problems. That doesn't cost the system pressure, burden, and money. Done.
Did you
Yeah.
all hear her say it doesn't matter? Compliance doesn't matter. You heard it. You heard it slip out of. I'm teasing. I'm teasing. All right. But you're right. Some of the changes that organizations are going to need to think about is they're going to have to review their benefit plans, right? And they're going to have
Mhm.
to review their communications and how they, communicate to their members. Hey, this is what's changing. These are your responsibilities. Here are our responsibilities. So there's a lot of work there in terms of updating that benefits package and looking as well into update systems to cap the costs. So there's a lot of in terms of claims and adjudicating claims, there's a lot of work in just the technical systems
Yes.
to update them to reflect the changes in the rule and this $35 or the change in the cost without getting
Mhm.
into the details. And yes, folks, I do have notes in front of me. I am looking at them and I'm proud of myself for that. I'm good with it. So there are things around claims processing and
Yes.
also working with the pharmacy benefits manager and what does that look
Mhm.
like? So there's a huge role in terms of operations and compliance, all of these discussions, and we're kind of running out of time for the moment. But hopefully, everyone's been thinking about this rule already and doing a little bit of planning. But in case, you've missed things, that there's going to have to be things like making sure that you keep track of negotiated prices, looking at provider and pharmacy contracts, making sure that those
Yes.
reflect the updated changes to the insulin. We talked about systems and IT, looking at monitoring and audit, and how is the compliance department looking at all these different areas and making sure that different systems in different parts of the organization are compliant with this change in insulin, right? And then really timing making sure that everyone's able to deliver on these changes. What is it? By? Is it now? Is it coming up? You said the deadline when
Yeah.
we first started up, but yep,
So let me double check. It is effective January 1st, 2026.
yep.
So they have a few more months.
A few more months, but there is the risk of overcharging. And how do
Yes.
you don't forget the training. Member services has got to be trained if you're part of an insurer. And then you've got not just member services, but you've got appeals,
Mhm.
right?
Yeah.
They've got to
Yeah.
be trained. They've got to understand. And all the training that goes on with maybe healthcare providers, like how do you
Mhm.
get that communication? And I'm probably
Yeah.
missing
And
various teams here.
yeah, the one thing that I was thinking about is making sure you're looking at your preferred drug list and making sure that whatever medications are considered insulin treatment are
Mm.
classified appropriately. What's going to apply? Is it only metformin? Is it something else? What drugs are in scope? And, there's a lot of GLPs that are in the
Mm.
market. Do those count? Do those not count? So I think you need to take a look at your drug list and make sure that you've got everything classified, because if a drug is misclassified, that pricing may not apply appropriately. And then you've got an appeal. So your appeals folks probably also need to be trained.
I didn't even think about that. Thanks,
Mhm.
Lori. But that's a big one as well. Didn't even occur to me. Is there anything else we want to say about the changes for insulin? But other than this is a huge impact to the industry and it will affect everybody from the patients to providers to payers. And it's a huge systems change as well. Anything else we want to add or are we ready to move on?
I think I'm good.
Okay. All right. So the next big topic we wanted to talk about is vaccines, right? And the rule, if I'm not mistaken, ladies, keep me on the straight and narrow. The
Oh,
rule
we
is
will.
saying, I know you, I know you will. For the most part, in short, vaccines are free in
As
general. Certain, yeah,
Mhm.
go ahead.
Mhm. Mhm.
So is it Part D, all adult vaccines recommended, this is technical here, sorry folks, recommended by the Advisory Committee on Immunization Practices
Yes,
are,
ACIP.
thank you,
Yeah,
those are free.
correct.
Okay, very good. So, what's that big change? Were people paying for their vaccines?
So there's typically two costs when you get a vaccine. And so things like the flu, that was always free typically, but there's an injection fee. So there's the actual cost of the drug, the immunization, and then there was typically like an injection fee for the needles, the syringe, all of that sort of thing,
Mhm.
and
Mhm.
disposal. So now they're saying, no, you can't be charged at all. and in some cases you needed a, a prescription. But many health plans, including commercial health plans, they already have them included. But this is anything that's on the Medicare Part D. D is prescription drugs. Anything under there will have no deductible and no cost sharing. So the no deductible, I think, is more significant than just the no cost share, right? Because even though there was previously maybe no cost share, they could still give you a deductible. Now they
Mhm.
can't give you either one. I think given that the current administration replaced essentially the majority of this committee, I think this is significant that they've made this decision. I think it speaks well that they're encouraging folks to get im- immunizations. Now, what's still up in the air is that COVID is not part of this schedule. And as you heard probably a couple weeks ago, the current administrator of CMS has said that he doesn't think that COVID should be by prescription, that or it should require a prescription. He doesn't think people should be able to just go in and get one the way you do a flu vaccine or pneumonia or whatever. So I think states are starting to sue for that right for
That's what we've
enrollees,
been seeing.
members to get that vaccine because they do see the value in it. So that one is still being litigated, but other vaccines and namely it's pneumonia and
Mhm.
COVID. Those
Mhm.
are the two big ones that when I think of this, I always think of. There's obviously a whole litany of vaccines that are also on there, but those are the big ones. And so this is again going to require Jessica's friends in configuration and claims and service center, the folks that are on the phone educating providers so that they're encouraging their patients to go get these vaccines, that sort of thing.
And it really does support. It supports public health goals, right? This is a good thing. Well, you're
Mhm.
talking about 3 people in healthcare that probably really value vaccines. For those of you that don't, I'm sorry. But many would argue, I'll try and take the middle ground here, that vaccines are a really great thing. So from a public
Yes.
health
Mhm.
perspective,
Absolutely.
um, being able to go get these vaccines at 0 cost is wonderful. It's amazing. At the same time, this initiative or this part of the rule supports the idea of no surprise billing,
Yeah.
right? You
Yeah.
shouldn't go to get a vaccine, and then you get charged for the syringe. Like to me, that's mind boggling. But again, this particular part of the rule supports that initiative around
Yes.
transparency and no surprise billing.
Mhm.
So, building on what you were saying for compliance, again, I don't know if it's quite as big a shock as a change to the system as maybe the insulin, but nonetheless, it requires a lot of the same
Mhm.
changes and the same kind of compliance oversight that the changes in insulin funding require. So, working with your pharmacy benefits manager, making sure
Yeah.
that there are communication systems updates, offering that training to member services. This is not a small task. Again, pretty big.
Yeah, and also making sure that if you're working in the pharmacy that you're training your staff that's administering the vaccines or doing the checkout at the register to make sure that folks aren't getting charged inappropriately. I think there also might need to be some claims reprocessing done if you are late to the game and you didn't realize you weren't supposed to
Mhm.
be charging a cost share or what's the word? Deductible. Sorry, English is escaping me at the moment. But to make sure that members are made whole,
Mhm.
that's really important. But having the conversations with everyone, so that when they're working with encounters or claims or whatever area, and the providers, again, I think it's huge to educate your providers. I don't think we talk enough about how important providers are in this equation because they're the ones that's going to remind the patient, hey, patient Lorie Davis, don't forget to go get your flu shot. Hey, you're eligible for shingles or pneumonia or whatever it is, don't forget to go get those. They're that person. They're the missing link. Your health plan may call you, your Medicare Advantage organization may call you, or your somebody may call you, but coming from your provider, it just means something different.
It does. Where the health plan, I think, comes in is around making sure they're not charging.
Mhm.
And the last thing I'd say is going back to what Lori was saying, this conversation about whether COVID should be included or not. I think we're going to need to watch what ACIP, any changes that ACIP puts out. I don't think this is a static space. So, any compliance team or department or organization keeping an eye on this vaccine conversation, you're going to have to watch for changes, right? I don't think, watch for changes in what's covered, what may not be covered going forward. So, that's like anything else, keep an eye on this. Okay. Now, this is a bit of a this is like insulin. This is a bit of a meatier topic, and we could probably talk about this for quite a long time. How about the rule talks about concurrent review and the right to notifications and appeals. And I honestly, until we started talking about this yesterday, I wasn't really very much aware. I don't know what that says about me, but I didn't realize the finer points of this part of the rule. And I think it's worth explaining to our listeners what's going on here and what this rule highlights and where it's coming from. Coming from, I don't mind saying it, it's in the public sphere around practices that Aetna espoused. And there's an element of trying to address those practices. Lori, do you feel comfortable, or Elvan, either one of you, going through what the issue is around concurrent review?
Go, Lori, go.
Oh, okay. So I tease this up as talking about midnights, but not in the Taylor Swift sense.
No.
Sorry. I had to.
I tell you, she
Anyway,
came ready today.
so there is a rule that has been out there for a while. It was most recently, up until this final rule, was revised in 2024. But essentially, it said, hey, patient, if you need to go to the hospital and be seen and treated in a hospital, you are covered under what's known as the two midnights rule, meaning that if you are going to be in the hospital and your care is going to require a stay of at least two midnights, you are covered at the inpatient rule. And that also makes sure that the facility gets reimbursed at the appropriate rate. There's also the option to treat as what's also known as observation or
Mm.
outpatient, and those pay facilities at a different rate. So there's essentially three rates that we're talking about. Inpatient pays the most, then there's outpatient and observation that pay at lesser rates. So all that is covered in law. We're good. Aetna is proposing to change how they manage this rule effective November 15th of this year. And they said, hey, if we are going to run it through our third party software, what you're being treated for,
Mhm.
and if we don't agree with what your provider and the facility say, we're going to change your rate. We will change it from inpatient to outpatient to observation. And you won't know until you get your bill from us. This is not subject to appeal rights. This is not subject to peer, which
And this is
means
Aetna
provider.
and
This is what Aetna is saying
for patients, for
for
those of us
patients.
who are yeah.
They're saying this to patients. And when I say peer to peer, that means physician A that's ordering the services cannot call somebody, a provider at Aetna, to have a discussion about this. There's no negotiation. Aetna is saying we are the final arbiter of what rate you as member, you as clinician and facility will receive. That is highly controversial, as you can imagine. So, what they've put in the final rule is they're saying, no, 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 you will have appeal rights if you are a Medicare member. Now, that doesn't help our friends in any other line of business, but it does help our Medicare members. So did want to kind of throw that out there. I don't know if Aetna is going to backtrack on this stance given what's in the final rule, because they cover members in all lines of healthcare, not just Medicare. They're in commercial, CHIP, Medicaid, ACA, etc. So hopefully that gives some daylight to what I'm talking about. Please feel free to go look it up. There's a lot of articles out there. Jessica, hopefully that helps.
Yeah, no, it's a really great summary. And the issue is, I mean, Aetna is deciding. So we talked about this and we were really puzzled yesterday when we were doing our prep, because the issue then is, how do you know, first of all, is the patient, what are you, first of all, what are you getting? How are you going to be paid? You finish your treatment, you get home, and suddenly you're slapped with the bill. You don't actually know what you're looking at and you can't fight it,
Yeah.
right? The other piece is that as a clinician, you have maybe less control. I mean, you've already
Mhm.
provided the services at that point based on your clinical judgment, what you thought the patient was going to need, only to find out that the insurance company has decided otherwise and you're not going to get reimbursed in the way that you thought. And in the meantime, you were just trying to provide the
Care.
patient care that you thought was required. This isn't the bit where we were gonna talk about Dr. Potter, was it?
Maybe,
No, I think
Lord,
this is a good place to talk about, well, I think we were going to do that later, but Elvin?
Well, hold that thought.
well,
Elva,
just a
go ahead.
quickly, just hold your thought. I want to ask, so how does this play with the transparency regulation? So I'm supposed to be told what I'm gonna get. It seems like these things are not hand in hand
No,
with
they're
each other.
totally in conflict, right?
Yeah.
So you have the
Yeah.
No Surprises Act, you have this
Yeah.
emphasis on transparency and making sure that there are no surprises, that when you get billed, you can track it, you can understand what's going on. So it doesn't track with no surprises.
Ay.
So I don't I don't understand Aetna. I know that there are a lot of challenges around payers and around their reasons, right? They're trying to manage their finances. But this doesn't bode well if Aetna carries on in that way. One wonders, I don't know. But
Well,
there
do you
is a
think they will have,
risk.
because then, okay, let's say that they are able to they're able to start doing this. Will there be a checks and balances system on the other hand to see if they are coincidentally always, not always, but in a statistically significant manner, bill for higher revenue, or like who's going to be on the other hand saying, okay, you're making the decision after the fact, but it seems like all your decisions favor your pocket.
Yeah.
And I mean, that's the intention, though. You would expect that of any payer. That's what they want. I would say maybe I'm a
Mhm.
little bit, maybe I'm a little bit, I don't know. What's the word? There's a word for this. Maybe I've been doing this for too long and I'm jaded.
Jaded?
But yeah, jaded, that's a good word. But I assume that this is what payers want. I mean, even with the government, when we talk
Mhm.
about cost
True.
savings, everyone's looking for their own pocket. We do it too. That's not necessarily a
Mhm.
criticism. But when you come to patient care, that is a criticism. I don't understand how you can change rates mid treatment. I don't understand how that works. That flies in the face of all the discussions and the government policy for the last several years. And I
Yeah.
don't think that's the thing. I don't think that payers will be doing, there's a lot of healthcare analytics to look at where they can make cost savings,
Yeah.
right? But I don't think they're going to want to they might look at their cost savings, but they're not going to necessarily look at patient outcomes. They're going to say, "Hey, well, we delivered what we needed to deliver, and that's it." But what I don't understand, and I think compliance professionals and organizations are going to need to realize, that there are a number of risks here, right? There are number one, making sure that the organization understands. understands the change, that there is a risk here in
Hmm.
changing the prices and changing the treatment retrospectively. There's going to be an impact on appeals. There's going to be an impact. I don't even know how you implement this kind of thing. It feels very more work than it's worth, but maybe the cost savings, like how do you implement a system where you
Yeah.
change the rates mid treatment and then you notify everybody? It feels like that's a lot of effort. And I wonder where the cost
Yeah.
savings really lie.
I
It feels like you would need two qualified people, one doing the treatment, the other one reviewing and making the decision. It seems like for
yeah.
the same job, you would need two clinicians, or at least one clinician who can actually do the clinical work and another qualified person to make the decision.
But it doesn't really work.
Mm-mm.
I don't see how that works, and we'll talk about that next time,
Yeah.
when we do look at Dr. Potter. That's a really great example of a really big gap in the system. Lori, you've been trying to say something.
No, I was also thinking in a lot of cases when a member's in a hospital, the insurance organization, the plan may not be aware until the member's discharged in some cases. If there's not a prior auth, if they came in under emergency situations
Mhm.
or emergent situations. So the plan or the insurer may not always be aware. So the member may go home thinking, "Hey, I was in the hospital for X days. I should be good." And then they get a bill and says, "Oh, you were treated as outpatient or you were treated as observation." And they'll be like, "What? But I was in the hospital," and not understanding that nuance of what that means for them. So I think this flies in the face again of what you were saying, Jess, with the Transparency Act. So
But Lori,
I
how
think
does that work? Like, in that case, who's making the decision about the change? Like, I don't
I
call me
think
naive, but I don't understand how the insurance company doesn't know. Like, who makes the decision there?
I think the provider makes the decision and it may trickle later, like when they get the actual bill to the
Mhm.
insurer. So I think it's a provider member situation and the insurer doesn't get involved till later if a prior authorization or pre-authorization isn't involved. I don't know. I honestly don't know that in every case to be true, but that for me is the one scenario I was thinking about, like members in, they're out, they're home, they think everything's good, and then they get the bill and they're like, "Whoa, wait a minute. What do you mean I was treated as outpatient? What do you mean I was treated as observation?"
And what this rule does now is give members, Medicare members, the right
Mhm.
to appeal, the right
Yes.
to fight it, and at least,
Yeah.
at minimum, question it.
Yes. Yes.
I, is it me? I know we talk a lot about Medicare, and we're about to end our podcast, and maybe this is a discussion for the future or one we keep to ourselves. I'm not sure. But I kind of wish all these benefits and rights. I'm so sorry if you're listening and you have a real disagreement with me. I'm sorry, but here it is. I kind of wish all these rights were applicable to a broader audience.
Yeah.
Absolutely.
Yeah.
Absolutely. But again, let's go back to what I said at the beginning. CMS, where it starts, everybody gets the wind of it. They
Yes.
realize that the writing is on the wall. So it's going to happen. It's just, you're right. It doesn't happen. And why, on a broader sense, I have to always understand that, yes, but of course, the elderly, the system should be protecting them. The assumption is that we know
Yeah.
better, we can fight for ourselves, but it will get there. It will get there. If it's,
It's
yeah.
I will say, Elvan, you make a great point because it did start with CMS, and I know of at least 2 states that have passed legislation that regulates the cost of insulin, and
Mhm,
in many cases, it also includes the equipment that goes with it, or it caps the equipment not at
mhm,
$35, but at a
mhm,
reasonable rate,
mhm.
relatively reasonable, and includes all the equipment that goes with it. So it is starting to catch fire, so to speak. So I think you make a good point, and I'm excited to
Mhm.
see what this can mean for millions of members and patients across the country.
All right, so compliance folks out there, we've got our work cut out for us, don't we,
Mhm.
ladies?
Yeah. Yeah. A
Yeah, we
lot to
do.
do. A lot to do between now and, in most cases, January 1st. But again, fiscal year starts October 1st, but plan year starts January 1st. So just a little nuance there, a little nuance. Get out your
That's all right.
calendar.
So with that, we're gonna close this episode. We didn't get to everything in the rule. Like we knew that there's
Oh,
too
yeah.
much to unpack. We barely had enough time to really flesh out the three topics we really wanted to talk about. And I feel like we really could have gone for a deeper dive. But we are where we are. In some ways, as much as there are challenges to the Medicare program at the moment and public healthcare policy, it is, on the other hand, really cool to be part of such a big change. And I think sometimes we forget that. You can
Mhm.
get really intimidated and maybe even bogged down a bit in the details and the scope of the change.
Mhm.
But actually, on a positive note, it's really cool to be part of it
Mhm.
and see where it goes.
Yes.
Absolutely.
Okay. Thank you, everyone, for listening. We'll see you next time. Take care.
See ya.
Bye-bye.
Bye bye.